time.
Oh, good.
9 o'clock is the meeting time.
Oh, good.
It's a sunny spring morning, and I'm at the end of a car trip that's taken just over an hour and a half. My guide to the Catalonian health system, Tino Marti, a health economist who works in the analysis and strategy office of the Department of Health in Barcelona, he's taking me on a tour of primary care clinics near Barcelona, Spain. In our last episode, Tino brought me to his workplace, where I learned all about how primary care is organized, funded, and delivered in Catalonia, one of Spain's 17 autonomous communities, kind of like provinces in Canada. And in today's episode, we're going to go on a tour of 3 different kinds of primary care clinics, all within driving distance of Barcelona. Tino's going to introduce me to the teams that work there and some special guests along the way. We've just arrived in a small town outside of Barcelona called Vilafranca del Penedès, with a population of about 42,000 people.
Oh, this is what we call the metropolitan area. So it's no longer Barcelona, but there's plenty of towns, mid-size, something between 50,000 and 100,000 inhabitants. It has grown a lot in the last 20 years because prices in Barcelona are really out of reach, and people prefer to sell the apartment that they have here and go to live in a small house in this suburban area.
Yeah.
Well, that sounds familiar, doesn't it? Vilafranca is considered the historical wine capital of Catalonia, known for its medieval architecture and its high-quality, well-loved wines. Though maybe not for Tino.
I'm not really a fan of Penedès wine, though. And then I prefer other denominations.
We've driven all this way to visit CAP Vilafranca North. CAP stands for Centre d'Atenció Primària, or in English, Primary Care Center. It's one of 3 primary care centers we're going to tour, 2 just outside of Barcelona and 1 right in the city center.
Did you have breakfast?
Not really. No, I didn't.
They promised us coffee and
perfect.
cookies.
Lucky me.
We're going to get a quick tour of this CAP. The primary care center is so important to the community that as we're driving, we pass a big sign on the highway marking the exit on how to get there, just like you'd see for a local hospital in Canada.
You see the CAP North? So it's announced in where it is, the public healthcare center.
So it's even on the street sign, is what you're saying.
Yeah.
It's such a big...
It's an institution.
Right.
Welcome to Primary Focus. I'm Dr. Tara Kiran, and I've been traveling around the world studying health systems with strong primary care in order to bring back lessons that could help strengthen primary care here in Canada. In our last episode, we talked about how primary care is organized in Catalonia, Spain, and its mandate to deliver primary care to 100% of residents, using what I think of as the public school model. Every community has a primary care center, and everyone in the community knows they have a right to access care there, whether or not they've registered in advance. And as we just heard, these centers are such an integral part of the community, they're even signposted on the highway. So today, we're touring 3 of these primary care clinics to see exactly how things work on the ground, whether it's in an urban or a rural area. But before we get there, here's a quick rundown of the details we covered in our last episode. In Catalonia, each patient who registers at a primary care center is assigned both a doctor and a nurse who follows them. Doctors and nurses, they work commonly in pairs serving the same roster of patients. Patients can usually choose their doctor or nurse depending on availability, and they can switch about once a year. Doctors and nurses, they work together with other team members, and the team composition is pretty standard across clinics. It includes receptionists, as well as a social worker, dentist, dental hygienist, nurse aide, physiotherapist, and a psychologist. Doctors, just like all the other staff, are on salary and paid to work 37 hours a week. The shifts are typically 8 to 3 or 2 to 8, Monday to Friday. If they do any after hours or weekend work, it's extra pay. And yes, doctors, like all staff, have vacation, sick leave, and a pension. And a portion of doctor and nurse pay relates to attainment of quality measures. We'll talk more about that in this episode. Now, the centers, they don't just serve those who walk in to register, but also those who are homebound or receiving long-term care in the catchment area. Doctors and nurses, they do home visits to serve those people. Family doctors in Catalonia, they typically serve about 1,400 residents in their practice, and nurses have similar-sized panels. I should mention that health centers have both family doctors and pediatricians. Family doctors, they care for patients 15 and older in Spain, and pediatricians care for those under 15. There's also one big concept you need to understand that we didn't mention in our last episode, and it's one of the things that makes the primary care system in Catalonia unique.
So you mentioned the Vilafranca. This is a publicly run primary care, a CAP?
Yeah. It's a CAP one, but this is managed by ICS. 80% of primary care centers are run by ICS. So they have sort of monopoly. It's a public monopoly of primary care.
Yeah.
Which is good and bad at the same time. It's good because this gives a homogeneous deployment of primary care across the country, across Catalonia. At the same time, it introduces rigidity because it operates as an administration, as a public administration.
And just to be really clear here, ICS stands for
Institute Catalan of Health, Salud.
So it's a public agency, basically, that's running the 80% of the primary care centers.
Exactly.
Is it like a non-for-profit agency or just a public agency?
Public.
So it's like the government is running it.
Yeah. It's the government.
But it's not the Department of Health, which does the planning, and then the
Catsalud.
Catsalud does the purchasing.
No, it's a different organization.
Organization.
The legal entity is a public enterprise owned by the government, but public enterprise with instruments that would help them to operate in a more flexible way, but they have not deployed them because of the pressure of unions and the pressure of political parties. And they operate like a police department, so really rigid. And we hope that with the reform that we are starting, we will be able to push them towards a higher degree of management capacity.
So, to simplify, the Department of Health does the planning, Catsalud does the purchasing, and ICS runs 80% of the clinics. Just like this clinic we're about to tour in Vilafranca.
Okay, so we're here at Vilafranca at the CAP North, I think, right?
CAP North. It's in the north side of Vilafranca.
For the other 20% of clinics, the health department hires specialized groups to run clinics for them. This could be a consortia where a city hall or regional government teams up with the ICS to run a clinic together in their area, or an EBA, which are primary care clinics run by a group of doctors or nurses who form their own company or nonprofit to deliver care. EBA clinics, they still need to follow the rules set out for care by Catsalud, but they have more freedom to manage their own staff and schedules. And importantly, they're not considered private clinics. They are publicly funded, and most of the clinics actually operate as nonprofits. Crucially, for the patient, the experience at any of these three types of clinics should be the same. Every community has a clinic, and patients who reside in that community can receive care there. Later in this episode, Tino and I visit both a consortia clinic as well as an EBA clinic.
Hey, Dani, ¿qué tal? ¿Cómo estás? Hola, ¿qué tal, Kiran? Daniel Ferrer-Vidal. He's the director.
But let's start with CAP Vilafranca, the ICS-run clinic.
Oh, thank you so much for having me today. Really appreciate it.
Tino and I, we were met by a few members of the team here to give a rundown on how CAP Vilafranca serves all of the eastern rural part of Penedès County. In Penedès, there are a total of 4 teams that serve patients, 2 in Vilafranca and 2 more in rural settings, one for the east and one for the west. Penedès has a population of about 350,000, and the CAP team serves 14 municipalities. In the room with us is Dr. Danielle Ferrer Vidal, who invited us to come see the center. Sarah Fregedes is the director of Penedès Rural East, and she's giving us a presentation about their clinics in Catalan.
La població assignada és una mica menys de la meitat.
Juan de Janelle, is that the director?
That's January 1st.
January 1st.
Oh,
Okay, so
And because I obviously don't speak Catalan, their community health coordinator, Marta Galtas, is translating. Here's Marta.
So the way it's organized, you have like one main health center where
Like
it
this.
has and it has attention during the morning and during the afternoon, from 8 to 8. And then you have the health points, you call it healthcare points. Health point, where they're not always open. They rotate, and usually it's only in the morning, right?
So the community has one central location, a center that's open from 8 to 8 and is in the more urban part of the region. But there are also rural centers that have been translated to me as health points, which are in spaces usually provided by the local municipalities. Residents can go there directly to see a doctor, but these health points are not always open. The 14 health points in Penedès rotate their hours, and when they are open, doctors are typically there 8 to 3, and then rotate back to the main center, which is open later. Doctors who work at the health points, they often also make home visits to the area to patients who can't make it to the health point themselves. The specific hours for each rural health point are determined based on the size of the town. And for towns that are smaller, with a population, let's say, of 1,000 or so, the health point might only be open once every 2 weeks. The doctors serving the community, they've often worked there for a long time.
Rural area.
Yeah, in rural area, it's very, they have a really close relationship. Like the people are really close to their doctors and their nurses because they try to keep them in their place for a long time, as much as they can. So it kind of like becomes like a long-term relationship because it goes from
L'últim que s'ha jubilat ha estat 42 anys en el mateix poble.
the last doctor that retired. He's been in the same town for 42 years. So it does become a close relationship.
The doctors in the health points, they also work closely with the municipality's social worker who can go out into the community and meet with patients in their home. Other team members also work locally.
In 2021, we started to introduce new professionals in their primary care teams, which are the psychologist, the nutritionist, the dental hygienist, and the physiotherapist. So these professionals came into the primary care teams with a very community health vision. So they are not as focused on individual attention, so they're more focused on group attention and also community attention. So they work on different spaces, and they're not doing all their attention in their city points. They also work in like city hall, the community basically.
Like I mentioned in the introduction to this episode, team members in ICS clinics like Vilafranca are paid on salary. That includes doctors, who earn an average salary of about 60 to 70,000 euros. But they're also given the opportunity to collect bonuses based on performance, up to about 5 to 10% of their total income. Tino says for a family doctor, the maximum bonus would be about 6,000 euros a year. Whether they get that bonus is based on specific indicators.
Accessibility, longevity, continuity, quality, and patient safety.
As someone who spends a lot of time doing quality improvement and who's always trying to get data for practices, I was really impressed when they showed me their dashboard of indicators. Managers get center-level data and can compare their center's performance with other centers. Physicians and nurses, they get data on their own panel, and they can compare their results with peers at their center in a way that keeps their peers anonymous. The reports include a whole host of indicators, including indicators on access, like the proportion of patients who could get an appointment within 48 hours, 5 days, and 7 days. I was impressed that they collect those access measures using a kind of secret shopper approach. A person on the audit team calls the center to book an appointment and notes how far away that appointment actually is and notes it down. Marta says that they try and stay on top of these indicators and are constantly trying to improve.
Each month they have a team meeting and they check at the results and they see where they were and where they want to go, and they talk about it and they propose some improvements.
And their attention to keeping these indicators on target, it's both to provide good care, but it's also motivated by teams and individuals wanting to qualify for those bonuses.
Okay. They focus on quality and assistance quality, and they try to give an attention that's focused on the person. They really focus on teamwork.
This team also has a strong focus on community engagement, and they often do that work in collaboration with local municipalities and local community organizations.
Usually each town has a building where they do activities for people of the town that, yes, for example, memory exercises, or so in order to create social activity between them so they're not as alone, to increase their health. But the main goal is to create
social participation.
Yes.
Okay.
And then but the center is collaborating with these?
Yeah, so the city hall knows all this information and they trespass it to the team, so they might work together in some activities.
So social prescribing.
Yes.
Okay, yes.
That's an example of this.
They created a calendar with all the events in the community that promote health. And while Marta says it's a big challenge to keep it updated, it goes a long way to encourage social interaction between residents in rural places and furthers health education. Marta says they started this adult health school a few months ago, and it's been incredibly well attended.
So each day they had a different theme. For example, it talks about eating. Another day might be about diabetes. We have this, how do you call it? When you write down how you want some things that are important for you when you die, that we have this document that you can fill.
Advanced directives.
So one of the sessions also talks about this document and what you need to fill if you want to do it. So we have different themes, and it rotates around the small towns, and anyone from rural east can come. Even if you are in a small town and you are from another small town, it doesn't really matter. You can go there and you don't even have to ask permission or anything, you just go there. Because we try to be close to the population and we try to go where they are, so you create this close relationship and so they don't have to move.
They also collaborate with municipalities that do research on what education the community needs. They call it a community health diagnosis.
So we do this research on
the needs of the community?
On the needs of the community. So when we create programs, we want the community to participate in this diagnose. So we know that we work on the needs that they really have and not what we think they have. So we're really trying to do this in all the small towns. So when we create these plans on community health, they're based on the diagnose that they've done before.
Marta says to perform this research, they work with an epidemiologist to help them understand trends in community demographics. And they also hold focus groups in the community so that they understand what's important to residents in order to ensure that they're providing services that truly meet community needs.
The relationship between the professionals, it's a good relationship and the coordinated together. How do you call that? We call it team climate, but I don't know how you... But they have a good team climate and...
so lots of good things that are...
And they are very proud of their team.
It was impressive to see in action how community is truly at the center of everything they do. After a great morning learning about how the ICS-operated primary care center works to serve the community, Tino and we've made another 40-minute drive from Vilafranca to Castelldefels, a popular coastal town about 20 kilometers south of Barcelona. It's outside the city of Barcelona, but still less rural than Vilafranca. We're here to tour another clinic, this time one operating under the consortium model, what they call the CAP clinic, CASAP. A reminder that means the primary care clinic is a joint venture between the ICS and the Castelldefels municipality. I recorded this trip in February, and so although Tino and I are wearing light jackets, it's nothing like February in most parts of Canada.
It's a beautiful lemon tree. Wow. It's really beautiful.
There are lemon trees in winter.
That's so interesting, though, that they grow in the winter?
They grow in the winter, yeah.
Oh.
Citrus normally are a winter fruit.
Citrus is definitely not growing outdoors in Canada at this time of year. Okay, so the clinic we're visiting pulls that citrus inside as well. From the outside, it's a pretty nondescript 2-story gray brick building, but inside, many of the walls are painted that same lemon yellow.
This is the main hall. They have remodeled this area to have to have tables as first contact. Mm-hmm. They have also in all centers, even in the other one, they have these systems now where you can do most of the procedures here. You can do it electronically. Yeah, it says go to work office number X. So instead of going to reception, you
Tino says patients can check in at the kiosk, but there's also a receptionist available if needed.
Let's go this way. This is the second floor.
So this is where you would see...
We are doing some remodeling on the nurses area.
Oh, okay.
I don't know how they are managing. This is the family doctors area.
Yeah.
Never too crowded because they are scaled by agenda.
Yeah.
And then there is office after office. All offices are similar, so when you will do shadowing, you will be in one of these offices.
On the main floor of this CASAP is pediatrics and an urgent care center. And then upstairs on the second floor are the primary care offices and other specialized services. Tino says the building is shaped like an H, which allows them to break the building into sections, but it does mean you get sunlight on all sides of the building.
You can see that you have sunlight because this H format is very convenient. This H format.
It's very nice.
We have here social work. Social work is here. You see 3 different social workers now.
So depending on the day or...
And this is interesting.
The eye doctor?
This is eye screening.
Oh.
For
retinopathy.
Retinopathy.
Yeah.
So they have this equipment here. They make the picture and they send the picture in case it's potentially pathological to the eye doctor, which will make diagnosis.
It's here on the second floor that we meet the 2 people who'll tell us more about the primary care center.
Yes, I'm Anthony Peris-Grau. I'm a family physician. That was another life. Since 20 years ago, I'm working as CASAP manager, CO, as you prefer to call it.
And me, it's Marisa Marti. I'm a nurse and I think com es diu?
Deputy manager.
Deputy manager.
And if you recognize Marissa's last name, that's because she's actually Tino's sister. Anthony says this CASAP began almost 2 decades ago, and their underlying philosophy is that they're always trying to be efficient with the health human resources that they have.
We started as a project to be as innovative and as comprehensive and resolutive as possible. The main idea was to solve every problem that primary care might solve, avoiding unnecessary referrals to other care levels. Everything that could be solved by the health assistants, those are professionals who are not clinicians, but work in the health services field, wouldn't be attended in a clinical office. Anything that the nurses could solve wouldn't be attended by doctors. And everything that the primary care could solve would not be referred by primary care doctors to the second level, to hospitals or to other services. So we've been working with that idea of mine for these 20 years.
Anthony says that in 2011, they also started a primary care emergency unit to reduce patient flow to the emergency department. The unit served to 37,000 patients in their assigned zone, but also a total of about 250,000 people from the areas outside of their zone. He says they also recently launched 2 other new services.
Since last year, we are also running a unit that takes care of the evaluation for the legal consideration of disability or dependency. And since October, we started a primary care team specifically oriented to support nursing homes. In our area, there are 15 nursing homes, geriatric nursing homes, plus 2 mental health nursing homes. And we organize a team of 6 professionals caring for these about 700 patients living in nursing homes. 700 people that most of them are in state of frailty or are complex chronic patients. So they need a different sort of care.
At CASAP, just like in the CAP de Vilafranca, public health is also more integrated with primary care.
One important thing that makes difference with, I guess that with Canada, but also with UK, for instance, that are the most similar organizations, is that most of public health activities are included in primary care. Vaccination, for instance, follow-up for healthy children, or screenings are not made by a separate team doing it in the community, but it's included in the activities that are to be developed by primary care professionals.
Just like is standard in all health centers, the team here includes professionals like physiotherapists, dental hygienists, psychologists, and nutritionists. Anthony shows me the hallway where the primary care offices are located. One side is that lemon yellow I mentioned, and the other hallway is a bright green. These hallways, they're close together but still separate, each with a distinct purpose.
And differently from most of primary care teams, we decided to separate nurses and doctors.
Oh, okay.
Nurses are in the green corridor, doctors are here in the yellow one, not because we didn't want them to talk with each other at all, but the other way around. We wanted all of them to be the most autonomous possible. So we wanted the nurses to be separated to avoid the doctor throwing patients to their offices or the nurses asking for help to solve situations. We wanted them to be autonomous. So that's why we made the different area distribution.
Anthony says they've always aimed to create a non-hierarchical organizational structure with common training and shared goals between doctors, nurses, and other health professionals. One of the ways they do this is by rotating work shift patterns to ensure all their team members mix and communicate regularly. Nurses play an important part of what Anthony calls a flat, cohesive team. They manage a variety of minor acute conditions like colds, urinary tract infections, or wounds, but they also spend a lot of time supporting care for chronic conditions like diabetes and high blood pressure. They also conduct home visits with the option of bringing a doctor or social worker with them if it's necessary. Just like in the center we visited earlier, team members here receive a fixed salary, regardless of the number of patients that they're assigned. Though the budget for the center is based primarily on capitation, that's a fee per patient that's adjusted for socioeconomic level and expected morbidity. And just like in the center we visited earlier, doctors and other team members can receive bonuses every year based on both team-based and individual quality indicators set by CAT Salud.
Here is the call center. For each shift, we have a morning shift and an afternoon shift. Like
and these are all health assistants.
Every primary care team has both face-to-face registration or online, or they may call.
Okay.
So we decided to have 2 people in the front desk and 4 people on the phone.
Okay.
Nevertheless, they may move depending on the activity. Okay. So they have also back office activity. For instance, calling back the patients to inform them about usually normality of the results, so they are not to come on purpose for doctor or nurse.
Patients who visit with CAP are assigned to both a doctor and a nurse. But here, they've also begun assigning more complex patients to a clerical staff member who can help them navigate their care. They're also working on supporting those clerical staff members with algorithms that can help them appropriately triage patients who call in. Anthony says that while they're operating a successful single-handed clinic, there are also some challenges that have come up along the way. For example, over the years, they've taken on extra services from the hospitals, but they weren't given the necessary budget allocation to cover the time and resources required. They also currently have a high patient-to-doctor ratio, with about 2,200 patients assigned to each doctor, which Anthony says should actually be capped around 1,900 patients. Anthony says it's hard to address this challenge through more doctor recruitment because the amount of workload is increased, but the center has no control over raising salaries. And making that problem even worse is that ICS-run clinics recently reduced their patient loads after doctors went on strike. That makes ICS-run CAP clinics much more attractive to new family doctors over CASAP and EBA clinics. Up next, we're actually heading to one of those EBA clinics. But as for Anthony, CASAP will keep working to live up to his dream.
We started with this idea to be not gatekeepers. I don't like it. I like to be gate openers, being advocates for the patients.
Yeah, I like that reframing. Tino and I were back in the big city for the third and last stop on our clinic tour.
So Tino, what part of Barcelona are we in right now?
We are at the edge of two neighborhoods, Gracia, that is an old town, and the extension of this old town towards the city center of Barcelona. So actually this was not considered Barcelona 100 years ago, it was Gracia, and because the expansion of the city and with this regional gridlock style of blocks, they connected the Barcelona downtown with the different villages around surrounding Barcelona. Socioeconomic average level. It's not rich, it's not poor.
It's also Tino's hometown.
In fact, I was grown here. So I was born in the other area where you are staying.
Yes.
But my parents moved here because my father was working in San Pau Hospital, which is walking distance from here. And we lived 2 blocks away to the left, and my school was 2 blocks to the right. So it is really close to my childhood.
We are in Gracia to visit the last of the types of clinics, the EBA, or Entitat de Base Associativa.
CAP Sardenya, they say that they are a university center because they have an agreement with a private university, University International of Catalonia, to train, I guess, doctors or nurses in this center. And this is an innovation that happened 20 years ago. A group of physicians decided to form a limited liability company, so for profit, and engage in a contract with the purchaser, the public purchaser CAP Salud. So under the contract, they provide primary care services to the basic health area of this neighborhood.
Tino says these clinics operate with much more autonomy because they can make their own decisions about staffing.
And they, for instance, can make a profit, and at the end of the year, share this profit between the partners or even the professionals in the team as an incentive, like a dividend on one side or an extra pay for salaried professionals.
Of the 3 kinds of clinics, the CAP, the consortia, and now the EBA, these EBA clinics, they're in the minority. Tino says of the almost 400 clinics in Catalonia, only about 12 or 13 of them are EBAs.
So it's really a small portion. It came in a moment where the government was more business friendly and encouraged this option to improve services, hoping that self-employment and autonomy would provide better results, which I think is partly true.
Tino says that since they were introduced in 1996, EBAs have not really gained much ground.
But it hasn't grown because we shift government more to the left side, less business friendly, and against private initiative, and betting more on public innovations.
Public innovations like the CAP we just visited. Our guide to this clinic, called CAP Sardenya, is Dr. Kiran Reyes.
Hello. Hi, how are you?
Good. Hi, I'm Tara Kiran.
Hi, I'm Carlin Reyes.
Hi,
I'm
Carlin.
from the Research Center.
Carlin is a family doctor, but currently she's not practicing because she's doing research. She's also currently the coordinator of the CAP Sardenya's research unit, and we're lucky she's going to give us a tour of the clinic today. The clinic is on the first floor of what appears to be a 6-story red brick apartment building. And they've really made the small space work with modular walls and dividers delineating the space.
It's a very compact,
Yes, because
well-designed spaces.
we have grown and we don't have much space.
Yeah.
All these are the medical consultations, and in the middle we have the nursery consultation, which would look on the other side.
Okay, so these are all the medical consultation rooms.
The clinic feels calm and modern, with blue and green tones on the walls and what seems like a signature brown wood lampshade hanging from the ceiling above most of the pods. This center, although an EBA model, which can be built as a for-profit venture, it's actually run by a nonprofit company. And because the owners of the company work in the center, it runs a bit like a cooperative. Any remaining money at the end of the year, it's put back into the center for the next year to address patient needs and add services or expand the clinic.
We started with the clinical area here, but then we have grown so much that we have taken the space next door for the private section of the clinical, the dental area.
Okay.
Because we're getting larger and larger, and we're still waiting because we're waiting to translate to another center, which is bigger, but it's still in construction. So
it's very beautiful. It looks very new, this center.
Because it operates as an EBA, this clinic has a direct contract with CAP Salu, but they have more flexibility to set their budgets because they're privately owned. Doctors also have more flexibility with their schedule. As long as the clinic is open 8 to 8, the clinic can set its own shifts for staff. CAP and CASAP clinics, in contrast, have strictly set shifts for doctors from 8 to 3 and 2 to 8. Doctors here also have the flexibility to choose areas where they want to focus more of their attention.
over here, every doctor has maybe chosen whatever they wanted for a specialization.
Yeah.
Okay, he is really linked into community medicine and to artificial intelligence also for the script and things like that. Doing research. We have another doctor who's specialized in geriatrics, and some other patient who maybe like more diabetes. So it's easier to maybe, depending on their interest, they'll just do more things or less. So.
And the EBA's partnership with the university means they're also one of the few centers in Catalonia that's actively engaged in research.
Is that a revenue source for you guys too, for the
Definitely,
research?
yes.
Yeah. So
a lot. Because pharmaceutical industry usually are always seeking for primary care patients to be included in their essays, and there's not a lot of medical doctors that can do it. Basically, we are the only center with a clinic. And Centelles, there's 3 other centers that have a research unit of their own. That means we have nurses that specialize in this. We have a statistician to do the analysis.
That's amazing.
So it's not usual.
That's very atypical.
From the patient's perspective, this clinic functions just like the other public clinics we visited. The team members are the same, and all primary care services are covered for residents. This clinic is also a training clinic, so they help train resident doctors from the university. Carlin says they have an innovation center focused on projects like the integration of social and home care to prevent hospitalization and institutionalization. Just like we saw in the other 2 clinics, nurses have a very important role here, in this case primarily managing chronic conditions like diabetes. They also help with home care and patient education. And when it comes to community building and health education, EAP Sardenya is doing similar work to the CAP and CASAP we visited.
Yeah, and I mean, one thing we didn't talk as much about is also the community orientation, because that was what struck me in the other ones I visited, just how connected they are to trying to serve the community. I think they even do these, it's like a health profile of the community to understand their needs. Is that something that you guys do?
Yes.
I thought it was it sounded like it was standard across many.
Because, I mean, here family practice is family practice and communities, medicina familiar y comunitaria, and which means that the integration with the community is it's constant. Mm-hmm. We do a lot of activity with the local schools and with the local centers of old people, and there's a lot of activities of just walking, doing exercise outside, or workshops that we do for healthy habits, either at the center or outside.
And those are the health professionals here at the center that do that? So the doctors,
nurses, health professionals, pediatricians.
Doctors as well?
Yes.
Family doctors. And so when you go into for example, when they go into the school...
The schools, for example, the pediatricians, they usually go to vaccine. They usually go also to make maybe workshops about screen exposure, about healthy habits. We also have activities that we work with the hospital. For example, recently we joined there was like a project for there was the Day of the Girl and the Science, because there's a lot of girls that by the age of 8 to 12, they just end up not being interested about scientific careers, and they want to promote this. And they did a whole activity in the Tibidabo, el Hospital de San Pau, and we participated, and we did a workshop with the kids about heart prevention and risk factors and with games. So we're always involved in different things.
Yeah, that's amazing. It's very different than in Canada, actually. Yeah. It's really nice to see that community integration. I'm just very taken with that.
That community integration is beautiful to hear about, and it's something I think Canada could really benefit from. But I think one of the reasons it's so ingrained here is because when you use a model like geographic empanelment, or where every person in a neighborhood is assigned to their local clinic, it means that as a patient, you have a long-term built-in relationship, not just with your doctor, but with the entire team at the center.
Yeah. This is the good thing about having always a stable population that actually visit you.
Yeah.
That means we're able to visit a patient since they were born until they're 65.
Yeah.
Because they switch to pediatrician at the age of 15, but they keep on staying here if they don't switch places to live.
Yeah.
So we have a really long longitudinality.
Yeah.
So.
I can't help but reflect that one of the reasons that Spain is able to guarantee primary care for all is that they actually put that guarantee into law, all the way back in 1985. I'm hopeful that in Canada, we can see that kind of change. After all, the Ontario government has taken that step and passed the Primary Care Act back in June of 2025, and I'm hoping that other provinces and territories follow suit. I love how in Spain, that geographic-based model allows for integration of primary care with community. And I can't help but notice that at a team level, there are doctors and nurses and others, each of whom seem to be working in a more coordinated way than often I see in primary care in Canada. Nurses have a very clear role, sometimes managing acute issues, but always managing chronic conditions like diabetes or high blood pressure. And they consult doctors only as needed, but otherwise work quite independently. And just like we saw in the Netherlands, they're working here to try and upskill the role of the receptionist. I love how they use data to really understand community needs, but also give feedback back to clinics and to support system planning. And despite being a bureaucracy, they're constantly innovating to do better. I mean, this is a place that had a health app for patients back in 2009. In Canada, we talk a lot about how primary care needs to operate more like the public school model. And in Spain, I feel like we found a system that shows it's possible. It's Friday, February 28th, just after 12 p.m. I'm sitting here just outside my hotel in the warm sunshine as I wait for my taxi. It's going to take me to the airport back home. In many ways, the primary healthcare centers they have here are ones that we dream about. A team of professionals grounded in community, serving their community, helping people with their medical problems, but also supporting people to live healthier lives. It's a system where no one is left behind. Everybody has a right to care. It's also a system that I've learned is constantly innovating. It's been a fantastic visit here. I've learned so much that I'm looking forward to bringing back. Hasta luego. I don't have it on tape, but this is also where I have to say hasta luego to Tino. He served as an incredible expert guide to both the health department and the 3 clinics we visited, and just to Catalonia in general. He helped me organize this whole trip. A big thank you to Tino Marti for inviting me, connecting me to his colleagues, and for fact-checking these episodes. And thank you to Tony Dedu and Jose Cerezo for introducing me to Tino in the first place. Thank you to my colleague, Dr. Catherine Rouleau, for putting me in touch with people from WHO Europe and helping me make this trip happen. A big thank you, of course, to all the clinic teams that allowed me to come, take a tour, and ask them a million questions. And a special thanks to Dr. Daniel Ferreira-Vidal, Marta Galtes, Dr. Sarah Freixeres from CAP Vilafranca, Marisa Marti and Dr. Anthony Perez at CAP Ganbu, and to Dr. Carlin Reyes from CAP Sardenya. And thank you to the many more people in these clinics who spoke to me about their jobs and the primary care system. We just didn't have time to include every single piece of tape. I hope you enjoyed traveling to Spain with me. Our team's going to take a summer break, and then we'll be back in September with some brand new episodes, visiting more Canadian practices, talking about some hot topics in health policy, and taking a trip to Denmark. See you soon. Happy summer. Primary Focus was created by me, Dr. Tara Kiran, and is made possible by funding from the MAP Center for Urban Health Solutions, the St. Michael's Foundation, and the Max Bell Foundation. Huge thanks to our advisors, Emily Holton, Seema Marwaha, Aaron Plenner, and Twinya Pham, and our research coordinator, Miriam Dinesh. Our producer is Avery Moore-Kloss. If you'd like to read more content from me about Canada's primary care system, join our Substack newsletter at primaryfocus.substack.com or follow me on LinkedIn. I put in a lot of work into these episodes, and I sure hope you're enjoying them. I always love your feedback and your suggestions for other things we can feature. Email us at primary.focus@unityhealth.to with your comments or suggestions. And if you're enjoying these episodes, please do follow us on your favorite podcast app. That way you won't miss an episode. And I'd love your support to get more people listening. You can do this by leaving a review on Apple or Spotify or any other podcast app. We'd also love for you to share this podcast with friends, colleagues, neighbors, because if we really want to build a better primary care system, we need to engage everyone in the conversation. The information shared in this podcast is for educational and informational purposes only. It's not intended as medical advice and should not be used as a substitute for professional medical care, diagnosis, or treatment. Always consult with a qualified healthcare professional before making any medical decisions or changes to your health routine. The views expressed in this podcast are those of the speakers and do not necessarily reflect the views of any organizations I may be affiliated with. Side effects of listening to this podcast may include a strong impulse to help fix the primary care crisis in Canada, a feeling of anger over how many Canadians do not have access to primary care, increased feelings of empathy toward primary care professionals who are just trying to make it work, and intermittent visions of hope that we can find a better way.